late good morning, early afternoon, and I understand it's me between you and lunch, so we'll keep this moving. So thank you for the opportunity to speak about patient-focused managed for the ILD patient. I work at the University of Pittsburgh. I'm faculty in the Department of Medicine and Pulmonary, but I'm a pulmonary clinical nurse specialist by background and have worked for 19 years with patients in our ILD center and realized pretty quickly that this disease has a great magnitude and patients and caregivers don't always appreciate the serious nature. So by disclosure, I currently have a grant from the National Institute of Nursing Research looking at integrating early palliative care for patients with IPF and their caregivers. Our target is 80 patients and caregivers, and we're at 73 and we'll be finishing in recruiting in December. I also have a small grant from Three Lakes Partners, and I'm on the Genentech Nursing Advisory Board for ILD. So the objectives today, I'm sorry I keep turning like this, the last session the thing was right there. Disease impact on quality of life, the role of palliative care, and resources to help you in your busy clinics. So I'd like to start with this picture. This is one of our patients. His name is Frank. Frank was so proud of himself. This is a typical Pittsburgh landscape with some rolling hills. And here he is on 15 liters of oxygen with his E-tank jerry-rigged to a gas lawnmower. And he brought that picture into our pulmonary rehab site and shared it with them, and he said, "Look what I was able to do." And they quickly said, "Frank, you can't do that anymore." But I think one of the important things about IPF is that it comes out of nowhere. Patients and caregivers often have difficulty recognizing the magnitude of the disease. We know that the disease progression varies, but the median survival is 3.8 years for IPF. So in this next picture, this is Frank on the right side. This is 8 months after his lung transplant. He's alongside two of our other lung transplant recipients. The woman on the left is 5 years out, and she's had also a kidney transplant from complications from her meds. And then the gentleman in the center, he's about 5 or 6 years out. But the important message here is while you trade one disease for another, these people are living. And they're at our annual pulmonary fibrosis walk in Pittsburgh. This study was just recently reported out of Europe, and what they did is they did focus groups with 41 patients with IPF and 17 of their carers, looking at communication needs, unmet needs for patients with IPF. And here is what they identified by working group, is that actually the working group is on the left hand, but we want to focus on the focus group. So the focus group were the patients and the carers. So the important things here are that they want to know about lung transplant, they want to know the financial impact of IPF, they want to receive reliable information and doctor-patient communication, they want to maximize their quality of life, they need patient and family support, and they want to know how best to achieve that. And then how do they approach exercise and pulmonary rehab? You've seen this multiple times, so I won't belabor this. But what we know with these patients is the disease is there and they have symptoms before they're diagnosed. And if they get to a specialty center, there's several papers out there that show that they're getting into the specialty center sometimes 2 years after their initial diagnosis. So I'd like to introduce this topic of progressive fibrosing interstitial lung diseases. And you may have heard that already this morning, but the natural history is characterized by a decline in lung function, worsening of symptoms, health-related quality of life, and early mortality. And these patients have worsening FVC and DLCO and worsening fibrotic changes on their CT scan, and their disease course is unpredictable. So if you take a look at this cartoon, in the center is the overall title, Progressive Fibrosing Interstitial Lung Diseases. And that is embedded within interstitial lung disease in the bigger picture, but it can affect, these PF-ILDs can be autoimmune in nature, exposure-related sarcoidosis, IPF, other ILDs, non-IPF, and hypersensitivity pneumonitis. And you all have those patients that just for some reason, they crash and burn, and they go downhill pretty fast. If you take a look at this slide, what we know is that PF-ILD, on the left column is the content, and on the right side are just some of the publications that support this. These are not the only publications, there are more. But we know that the patient has a shortened lifespan, they have a variable disease course, tremendous symptom burden. It is a huge impact on their caregiver. They have limited treatment options. They have a need for supportive oxygen and palliative care. And this is a really nice cartoon that describes this myriad of symptoms that the patient experiences. So shortness of breath, cough, fatigue, deconditioning. It becomes this spiral of disability because they do less. They become depressed. They become anxious. All of these symptoms affect their quality of life. This study was reported last year, and this was done in Europe, and they reported that on an SF-36, these are the 8 categories on the SF-36. So if you take a look, physical function, general health, vitality, mental health, role, their physical role, emotional role, social function, and bodily pain. And what they found were there was a marked deterioration in quality of life in the last 2 years with IPF. And this is the first study that demonstrates that IPF patients have this low health-related quality of life already 2 years before death, especially in their physical role. Now, you're probably thinking, well, that makes perfect sense, because we see these patients when they come to see us, and they're limited in their ability to do physical activities. It's rare that you have a patient come to see you without a caregiver, and so it bodes the question, where are those patients that don't have caregivers? And the reason I say that is these people come and they are on a lot of oxygen, and it's difficult for them to bring it by themselves. So that role of the caregiver is so important. So it's important that as providers to check their symptoms and their health-related quality of life, and this is to address the palliative care needs. So symptom burden, we know that these patients, as mentioned earlier, experience all of these things. And they also have a high propensity for comorbidities, which contribute to their symptom burden. So all of these are associated with a decreased quality of life. Now for cough, it's important to evaluate it for causes other than IPF, such as esophageal reflux disease, postnasal drip, and treat accordingly. Treat with opioids if the cough is debilitating. For shortness of breath, this is from the NICE guidelines and from Bajwa in the UK. If the person is breathless on exertion, assess for causes of breathlessness and the degree of hypoxia. If there's a need for ambulatory oxygen therapy and long-term oxygen therapy, and pulmonary rehab, advocate for that. If the patient is breathless at rest, you do the above. Plus, you also assess the patient's psychosocial needs and offer referral to relevant services such as palliative care, and then early use of opioids and low-dose benzodiazepines. So this cartoon here it talks about non-pharmacologic treatment, and we'll start at the top and go around to the right. So for oxygen, as mentioned earlier, there is no specific recommendation other than what's suggested in the ATS guidelines. And we do have a need for more data, particularly in these patients with ILD. In regards to invasive ventilation and ECMO, there's few data about this. Non-invasive and high-flow nasal cannula, it's you should consider it an acute exacerbation, but there's, again, low-quality data. Pulmonary rehab. This is one, like, here's my personal bias comes out. This is one of the most important things that we can do for our patients for several reasons. You can't fix what's happening in their lungs, per se, with the disease, but you can improve their functional status, and you can also impact their emotional status because they're getting out of the house, they're with other people who are going through the same thing. And another really important role of pulmonary rehab is they serve as your eyes and ears. They're the ones to tell you often that so-and-so has an increased need for oxygen, or so-and-so has an infection, has a fever, and you may not see that patient in between your visits. So pulmonary rehab is really, really very vital in helping with those communications. Palliative care, we're going to talk about this in a little more detail in a few more slides. And then your general measures, quit smoking, vaccination, nutrition counseling, and then early referral for lung transplant consideration. So palliative care's role in quality of life. I've been doing a lot of research in this area and doing a lot of reading, and one of my former bosses, I just read something last week, and it was kind of like, oh, this aha moment. We all do palliative care. So you do palliative care in your day-to-day practice when you order pulmonary rehab, when you address the oxygen needs. That's palliative care. You're helping to support the patient, so you do that. So I think sometimes we stumble in the wording, at least that's what I'm finding, is that many people are afraid of it, both clinicians and patients, but we need to just break it down into what it is truly. So palliative care, last year the Center to Advance Palliative Care, it's housed within Mount Sinai in New York City, and they reframed and redefined palliative care. So it's the act of bringing people together to ensure that all those with serious illness, such as IPF, receive the care they need in the right place at the right time. And this really the playing field kind of changed back in 2013 when this paper was released by Temmel in the New England Journal, that they took a look at the role of palliative care in patients with non-small cell lung cancer, and their hypothesis was patients who received early palliative care compared with those who received standard oncologic care will have a better quality of life, fewer depressive symptoms, and less aggressive care. They recruited 151 patients. 107 completed the study. 27 died during the interval, and the remaining were lost to follow-up. But for that group that was assigned to palliative care, they had a better quality of life, they had fewer depressive symptoms, they had less aggressive care, and they had a longer survival. So this really changed the playing field. So you'll have those patients that when they get their diagnosis, they will say, oh, thank God it's not lung cancer. Well, I'd like to show this slide. So this was a comparison of 5-year survival rate for IPF and different forms of lung cancer. This was by Venturi in Italy. And if you take a look along here, patients with IPF actually had a worse survival rate than some patients with lung cancer. And you see how it compares with these other cancers. So the takeaway is that IPF, PF-ILD, these are serious illnesses that patients have a unpredictable disease trajectory, if I can talk here. So palliative care and chronic diseases. This is one more study just to go through this. Biernot reported in this study, they took a look at the referral to palliative care with certain chronic diseases. In patients with COPD, 20% were referred for formal palliative care, 34% for heart failure, 37% for dementia, and 60% for cancer. So in our patients with non-malignant lung disease, there's definitely a role for palliative care. So how does this differ from hospice? I can tell you multiple times that patients and also some of the clinicians I work with say, I don't really want you to use the word palliative care. I don't know what it is. I don't like it. And there's often a thought that it is hospice and that you're giving up. But the breakdown is hospice is provided when a patient is thought to have less than 6 months to live. It's a focus on comfort and pain relief, and the patient forgoes any aggressive treatment, including their antifibrotics. And that sometimes is a game changer for patients for enrolling in hospice, just something to be aware of. Now, it's important to let the patient know, and also for the provider, you can reevaluate every 6 months. An example I'd like to give, we had a patient who was on 15 liters of oxygen, lived by himself, and was declined for transplant. And so our pulmonologist referred him to hospice. He lived for six more cycles. He lived for 3 more years after he started hospice. And the reason was he received all these services that focused on his comfort and improved his quality of life. Yes, that is an outlier, but the important takeaway message is that what we find often is that patients don't benefit from hospice like they should. They're often referred in the last week of their death, and there's a lot of resources that focus on their quality of life that they're missing out on. So how does palliative care fit with hospice? So here on the left side, so at time of diagnosis of any serious illness, patients should be referred to palliative care, and we'll talk about how to do that. But palliative care can be provided alongside disease-directed therapies such as your lung transplant evaluation, your antifibrotic therapy, whatever the medications are. The whole focus of palliative care is just we want to improve their symptom burden and decrease their symptom burden and improve their quality of life. This is another schema of integrated palliative care model. So patients may be healthy when they first get this diagnosis, in that they get it by chance, the diagnosis, and they're not experiencing a lot of symptoms. So you can start to see that the role of palliative care increases as the patient progresses through their disease. Now, there's a difference between primary palliative care and specialty palliative care. So primary palliative care is what you're doing in your offices when you see patients, and it's delivered by the clinical care team, compared to specialty or secondary, which is delivered by an interdisciplinary team. So optimal palliative care for patients with chronic lung disease should include both. It's not always realistic or feasible, but that should be the goal. Of note, there is a national shortage of specialty palliative care providers, so a lot of it will fall onto your plate. And in one study, patients reported that they didn't know what the word palliative meant. They didn't like it because they didn't know what it was, but they often felt that they liked the word supportive care better. So we have a study where we look at palliative care equals quality of life care equals supportive care. The bottom line is we're trying to decrease your symptoms and improve your quality of life. This study this paper was released in 2017. This was an effort of international guidelines on the role of palliative care in interstitial lung disease, and that optimized quality of life care includes symptom-centered approaches, best supportive care, caregiver-centered management, disease stabilizing care, patient-centered management, and end-of-life care. This is this study that I mentioned. This is what we're doing right now in Pittsburgh. So it's a randomized clinical trial of an early palliative care intervention entitled Support, and it's for patients with IPF and their caregivers. And it's an intervention that includes information about the disease, self-management strategies, and an introduction to advanced care planning. Patients with IPF are randomized to either receive the intervention or not. If they receive the intervention, we have a nurse interventionist. They complete questionnaires, and then the intervention support, it's a book that I wrote, and we'll talk about it then a little more, but she sits and she reads the book to the patient and their caregiver. It takes approximately 15 to 30 minutes, and the patients are appreciative, particularly the caregivers, she said, because she said they want to know what's going to happen as this disease progresses. If they're randomized to the usual care, what happens is they complete the questionnaires, they get our usual patient education information, and 6 months later, then they get the intervention. So the support, this is registered through our University of Pittsburgh Innovation Institute, but this is what support includes. Information about symptom management, understanding your disease, pulmonary rehab, palliative care, oxygen therapy, research opportunities, and transplantation. I feel very strongly these are all the things that a patient with any chronic lung disease should receive information, and I think that you could switch out the U and some of the management, and this could be for advanced lung diseases, advanced COPD, and we're actually looking at expanding in those areas. Jeff Zigris from National Jewish has this really important paper that he was published in 2018, and it talks about the transitions and the touch points for patients who have IPF, and then this is along their disease course. And he describes that there's 4 time points during the course that herald this period of transition and a big area of change for patients. So the first is when the patient receives the diagnosis. The next is when oxygen is prescribed for the first time with exertion. Then when oxygen is needed at rest, and then when high flow oxygen is required, and that portable concentrator or whatever their lightweight is not meeting their needs anymore. And so these time points are when patients need a little extra care and support from their practitioners. So in conclusion, ILDs are complex. Education and clarity of communication are essential for the patient and their caregiver to understand and appreciate the magnitude of the disease. I have to share with you one key point. When I first entered into this world, I had worked in general pulmonary outpatient at the University of Pennsylvania. Then I came to the University of Pittsburgh when we started this new ILD center. I would go in and do the history on the patients, introduce them to the concept of our clinic, and then the physician would see them, and then the physician would come out of the room. And I would see the patient and the caregiver come out. And the best way I could describe it is they had this blank stare. They didn't understand or appreciate the magnitude. So we did a pilot study looking to see what was the disease magnitude of IPF for these patients. And what we found was that over half were depressed. 3 of them in a cohort of 28 had severe depression, 2 had suicide plans. And they didn't understand what their future looked like, but it was very depressing to them. If they had good quality of, or good supportive care, meaning good family members, friends, they had a better quality of life, and vice versa. And the reason I say this is I think that it's really important when you care for these patients, you think about this. A patient's given a diagnosis of idiopathic pulmonary fibrosis. Okay, 12 syllables, if you get it right. Think about, you'll hear patients say, oh, my doctor says I have interstitial pulmonary fibrosis, or I have something with a U in it. There's so many different words and, just ways that you can describe it. Patients don't always appreciate that diagnosis. compared to if you tell a patient that they have lung cancer, what's the natural response? Oh my God, that's bad, I'm gonna die. But there's this disconnect in timing where patients don't always appreciate what idiopathic pulmonary fibrosis is. They often go home, their family members ask this, because they come back and they tell us this. Do you have cystic fibrosis? Because the only word they know that's familiar is fibrosis. And so I think that it's really important when you see these patients to deliver these messages to them. But idiopathic pulmonary fibrosis, unknown lung scarring, or these PF-ILDs, progressive lung scarring, that we don't know what's causing it, but we are here to help you. There are resources that are available, and we're here along the way. I think that just the delivery to help these patients is crucial to help them live through this disease course. Participating in support groups and research studies offers the patient the ability to actively manage their disease. Different ILDs can have different or similar symptoms and complications, so it's important to address them with symptom-specific treatments, including pulmonary rehab and supplemental therapy, and then the meds that you heard this morning. And because the disease course is unpredictable, it's important to initiate palliative care early after diagnosis to optimize symptom management and address advanced care planning. And these non-pharmacologic therapies are crucial to help support the patient and their caregiver as they live with their ILD. Some resources that are complementary for patients, they're on the Pulmonary Fibrosis website, the foundation website. Last summer they did 12 videos, and they're 3 to 4 minutes. They're really nicely done, and they're a great resource for your patients when you don't have time in your busy practice. You can refer them to these resources. And then for providers, we did a 30-minute video with the PFF last year with Global Academy, and you can get CME, and it gives some examples of conversations along the disease course of IPF. So this is that resource that I mentioned about the Pulmonary Fibrosis Foundation. And then lastly, I'd like to close on a positive note, because I realize this is kind of a depressing subject and can really stifle conversation. But at our center, we have a yearly golf outing. Our mantra is we want to have our patients live with their disease in the best possible way that they can. So at this, we have this patient who owned a golf course. It was his idea. He said, whatever you make is yours, and we use that to fund our support group. So for this yearly golf outing, patients can golf for free. If they're not golfers, they can play bingo in the afternoon. We have a dinner in the evening and a short presentation. But our hospital-based durable medical equipment company provides oxygen throughout the day. So it's a way for patients to get out and live. And then this is my favorite slide of all time. So this is one of our patients. So this patient is Joan. She asks me every time, where did you take me and what did you say about me? And she wants to know. She just wants to know. But she's the healthy adaptation of getting the diagnosis. She came out and she said, oh, this is a really bad thing, but there's still a lot of things left on my plate that I want to do. So here she is in Australia, dancing with the natives with her portable oxygen concentrator. So she said, please take this around, share this with patients and anyone else, and let them know that you can live with this. So with that, thank you.